back in 1980s when I was doing my residency. The primary indication, which still remains the primary indication, is a progressive neurological deficit, which was the main indication for surgery related to the disc. But as the economics and the living standards and various other social factors are changing, the surgery related to the disc is more and more for management of the pain coming from the disc rather than only the neurological deficit. When you are choosing a patient who has pain coming from the disc, we must realize that the patient's brain has already localized the problem, and the patient is narrating you the history and the symptoms. So for you, you need to correlate the symptoms with the images and then come to a conclusion how to target that spot which is causing the pain. So my talk is essentially about case selection, surgical planning, and how do we access this problem, especially in a patient who has a fragment causing the sciatic pain and backache. Now basically the basis of this selection is we understand that the patient's symptoms are arising because of the response of his nervous system to the change in the anatomy. And the change in the anatomy is mainly restricted to the posterior annulus of the disc. You would appreciate this point that the symptoms are not arising from the anterior 2/3 of the disc, but they are arising only from the posterior or the posterolateral part of the disc. And I normally try to highlight a simple point that you have the nucleus inside the disc. You have an annulus, which is the barrier between the nucleus and the nerve, and you have a nerve root outside the disc. Normally, since the annulus is intact, there is no connection between the nucleus and the nerve, and then you have an annular tear which causes the nucleus to come in contact with the nerve, which gives rise to the symptoms. This is very important. All of us sitting here, for example, have the nucleus inside the disc which is not interacting with the nerve, so we are asymptomatic. The moment you have an annular tear, you start getting symptoms because there is a break in the barrier. And we also realize that the claudication is caused by something else. We are primarily targeting our efforts on the annular tear and the fragment, which gives rise to sciatic pain in most of our patients. Now, most of us have knowledge about the degenerative cascade, which has been described by Kirkcaldy-Billis, where the cascade is there is a dysfunction of the disc, there is instability, and there is a natural stabilization as the cascade progresses. This has been described very well, and all of us are aware of this. But there is a big limitation of this study, and the limitation is this basic study is not a neurophysiological study. This is a study of 20 cadavers, and the anatomy has been highlighted where the changes in the disc have been described, but the physiological aspect of the disc has not been studied, except in the lower paper, which talks about this paper, which talks about the relation of the nerve root to the changes. Now, I would like to emphasize this very simple point that we must understand the nerve supply of the disc, and we know that the nerve supply of the disc is, number one, only on the periphery of the disc. It only covers the outer third of the annulus. There is no nerve supply inside the disc. There is no blood supply to the disc. Actually, the disc is one of the largest avascular structures in the body. And the symptoms which are related to the disc arise from the posterior annulus or the posterolateral corner, which has got a dual nerve supply. And all the symptoms which the patient is talking about are arising because of this nerve supply. So our efforts are directed to targeting this area of the disc because that is where the symptoms are coming from. And I would like to bring to your attention this paper in JBJS, which talks about pathology and the possible mechanisms of nervous system response to the disc degeneration. The point in this paper is very simple. It says that the symptoms arise from the response of the nervous system to the changes which are occurring in the posterior annulus. This is very simple, a very refined way of thinking about the symptoms which are coming from the disc. And I would like to bring your notice that what is the outcome of discogenic sciatica and the pain generators. The outcome depends on the time frame and the level of cytokines. What I mean is there is a piece of nucleus. There is an annular tear which is allowing this piece of nucleus to come out and irritate the nerve and give rise to inflammation and mechanical compression of the nerve. And if you have absorption of the nucleus, healing of the annulus and a relief of the inflammation, then you would have a positive response which would be in the form of relief of pain and restoration of the function. Or a negative response where there may be a partial adherence of the root to the disc and a persistent pain. Now these are the people who come to us for relief, and we intervene in these people where there is a failure of natural resolution of the inflammation, or there is a persistence of pain because there is a piece of nucleus sitting in the annular tear irritating the nerve chemically or mechanically. So what I am trying to convey to you is the patients whom we see with persistent pain, we need to find out where is the piece, where is the fragment next to the nerve, and where is the annular tear. So all our efforts are then directed to this. Now I normally ask these 6 questions in my patients when I am trying to select a patient. And the questions are based on the patient has persistent symptoms where the natural resolution of the inflammation around the nerve has failed. The natural recovery has failed, or you can say the conservative treatment has failed, and we do have, or we may not have, a correlation with the image. We have a patient who is aware of the symptoms, and we are aware of the paradox in the image and the symptoms. What I mean is, you may see a patient where the MRI looks normal, but the symptoms are very severe, or the MRI may look very bad, but there are no symptoms. So we understand that MRI alone may not help you in choosing your patient for surgery or for intervention. And as you are aware, when we clinically examine a patient with backache and sciatic pain, most of our examination is based on change in the pain on the movements of the spine, that is the directional preference related to the pain. That is what happens to the pain on flexion, extension, side bending, raising of the leg, straight leg raising, etc. And it may happen that the patient may not have a positive straight leg raising sign, but the patient may still have pain because it is more of chemical irritation. So I ask these 6 questions. The first question is, where is the pain coming from and why is it persisting? Why is it that the pain is not going away in spite of 6 weeks or 12 weeks or whatever time which has passed from the start of the pain? Is the pain along the sciatic nerve distribution, dermatomal or sclerotomal as we call it? We are aware that the dermatomes have been described about 100 years back. They have not been updated. There is no refinement in the description of the dermatomes. So many times we have overlap of dermatomes, and just thinking about the dermatomes will not give you a precise diagnosis. The next question which we ask is the distribution in a particular root distribution? We are aware that there is an overlap of roots supplying to a particular part of the limb. If it is the root, which root is involved? Then we ask the next question, is it because of the disc? And we do what we call the Mackenzie's test, which I will describe in the next slide. If it is the disc, which disc is affected? And we do a non-invasive and then an invasive assessment of the morphology of the disc. And then we make a mental guess or a guess on the image, where is the fragment which is causing these symptoms and where has it started coming out of the disc. Now Mackenzie's test, I have just thought of showing you this diagram. All of us are aware, but most of us are not using it in clinical assessment. What this test means is, when you're seeing a patient who has pain like this, you ask the patient to extend or flex. Most of the times with extension, the pain would centralize, the pain would come here. The peripheral part of the pain will go away. What it means is the annulus has a good integrity, and there are patients who, if they centralize like this, then maybe they would respond to conservative treatment because the annulus has good integrity. And we also use this test on the table during surgery. At the start of the surgery, the patient has peripheralization, that is, the patient has pain something like this. When he extends on table, the pain is going down the leg. At the end of the surgery, the pain should stop. The pain should not peripheralize. So we use this test for diagnosis as well as during surgery. Now I would like to bring to your notice some papers from spine which are talking about the effect of the nucleus pulposus on the nerve root. And this paper from spine in 2004 January is a very, very important paper which talks about the effect of nucleus pulposus on the neural activity, on the mechanosensitivity and the sodium channel expression in the nerve. This is a very, very important paper. I would ask you to go through this paper very well. And this emphasizes the point that the nucleus pulposus induces certain changes in the nerve, and these changes give rise to the basis of the symptoms. And here there may not be a mechanical compression, it would be just a chemical irritation of the nerve. There are a few more papers which highlight the same fact, that we can have a chemical sciatic pain. And I can bring to your notice this slide. I did a discogram in this patient. This needle is in L5S1, this is in L45. And the moment I injected L45, the dye immediately leaked in the root sleeve. Now this patient had a normal looking MRI, and the patient was labeled as a psychological problem because there was nothing found in the investigations. And the patient was told that you probably have something here rather than in the back. What I would like to tell you is that before labeling somebody as a psychological problem, we should be very sure that we are not missing this. I find in my patients, about 20% of the patients have a chemical radiculitis rather than a mechanical compression giving rise to pain. I can treat this very well because I know where the problem is and I know what is causing the problem. So you should also try to search whether you are dealing with a chemical radicular pain rather than only a mechanical compression. Now coming back to the basic question, where is the pain coming from and what is it that makes it persist? I would bring to your attention this very, very important paper by Stephen Kuslich about the tissue origin of low back pain and sciatica. Now this paper talks about more than 700 patients who have been operated in the traditional posterior midline approach. They were operated under local anesthesia. Now what was done was a serial local anesthesia was given. That is, you probe a structure. If it is painful, you give local anesthesia and then proceed down up to the disc. So you incise the skin, you probe the subcutaneous tissue. If it is painful, you inject, then cut it, then go to the next level. And what was found was, in cases of sciatic pain, the only structure which was involved is the inflamed mechanically stretched nerve root. And in case of backache, which was significant, the pain was coming from the posterior annulus or the anterior facetal capsule or anterior dural structures. That's it. All other structures were not very significantly involved. This is a very, very important concept because it allows me to operate all my patients under local anesthesia. Mind my word, I operate all my patients in awake and aware state. All of them are totally awake throughout the surgery. We do the surgery under local anesthesia. Why? Because the pain is coming from a very, very limited area in the back. The whole back is not involved. So we don't really have to cut many structures. We just concentrate on the foramen. Why? Because all the pain generators, as we call them, are situated in the foramen. They are not in the supraspinous, interspinous area, not in the interlaminar area as such. They are more in the foramen. And then of course I would bring to your notice these other papers which are also important, talking about where is the pain coming from and what really makes the pain persist. I for one, I normally describe it as path A and B. What I mean is you have certain changes inside the disc but the outline of the disc remains normal, and it is a chemically sensitized disc. And you have path B, that is, you have a tear in the annulus with a fragment coming out and irritating the nerve. Most of the surgical candidates are these. Most of the candidates which need injections or steroid injections are these. But in practice, you can have a combination of both. You can have an annular tear which is leaking and an annular tear with a fragment. So it may be like this, where you have a normal disc, a disc which has a small grey band, a further blackening of the disc, a black disc, a T2 weighted image, and a collapsed disc. But the outline of the disc has remained more or less normal. And you may have a disc like this, where you have a fragment coming out at various stages, pushing the nerve and giving inflammation. Maybe this is a candidate who may need a surgical intervention. Whereas, and mind you, all these images, the patient may be asymptomatic. The patient may not have any symptoms. What gives the symptoms is the chemical irritation and the inflammation, which is obviously not seen in the MRI. Now what we do is, we confirm that our target is this. Our target is the fragment which has come out of the annular tear and is sitting next to the nerve, giving rise to chemical irritation and inflammation. And we also understand that in these patients there is a loss of distinction between the annulus and the nucleus. What I mean is, the nucleus annulus distinction, the image is not there. It looks more or less similar. This looks black. And we also try to understand how is the fragment behaving over a period of time, in the short term or in the long term. Now this is a picture which I took from a paper in Spine, which gives you a three-dimensional understanding. This is a normal disc. There is a small bulge here. There is a bulge which has a focal protrusion. This is a protrusion with a broad base. This is the exclusion, and this is the sequestration. Now, from the traditional point of view, we are looking at the disc from outside. But for an endoscopic surgeon like me, I look for the problem from inside. You must be aware that the annular tear, in case of a degenerative disc, starts from inside, goes out. And that is why it doesn't heal. A traumatic tear of the disc starts from outside, but it heals because there is a blood supply to the disc on the outside. There is no blood supply to the disc from the inside. So the tear which starts from inside and goes out never heals. It remains persistent. So for an endoscopic surgeon, I look for the tear from inside. So this is a perspective which I use, but I am more interested in looking on the inside of the disc. Now what I do is, after my clinical examination, I come to a conclusion that a patient has a problem at a particular level, and there must be a fragment which is sitting at a particular level, maybe central, paracentral, foraminal, extraforaminal. And then I keep the MRI and the X-ray side by side, and I try to mentally visualize where would be the fragment on the X-ray if I try to extrapolate the fragment. What I mean is, the MRI may show me a fragment which is paracentral at L4-5 on the left side, for example. Then I try to imagine that the same fragment in the X-ray would be at a particular location. So that as surgeons, all of us are thinking in space. We are trying to sort of visualize, is the fragment here or here or here or here, like that. And for that, what I do is I put this scale on the back of the patient and make a mental guess that, am I in the center, am I on this side or this side? Now the point of showing you this picture is that the distance between the pedicles is not very big. If you measure the interpedicular distance, it doesn't go beyond 20 to 25 millimeters. It's a very small distance. So what I mean to say is, when you put your scope or the cannula inside, you're not going to cover a whole lot of distance. It's just there. You just have to go a little ahead or a little back. So what you're trying to do is, we are trying to locate the fragment on the X-ray and the C-arm. Now why we try to locate the fragment of the C-arm is because the first part of the surgery, till you put the scope inside, is entirely under the C-arm. You're proceeding by the fluoroscopy. And what we do is, when we position the patient on the table, we imagine that the patient is being put in a matrix under the C-arm, and then inside the patient we have a mental visualization that a fragment is sitting in a particular axis. I know this may sound very complex, but tomorrow we should be able to show you what we do. as Stefan has already shown you, what we do is we are trying to go here in the foramen. Normally the entry would be about 10 centimeters from midline, and we are trying to access the under surface of the posterior annulus. I would repeat that statement. I am not trying to land on the disc, I am trying to land below the fragment inside the disc. So I am aware that the symptoms are coming from the posterior annulus. I am aware that there is an annular tear which is allowing the fragment to come out. So instead of landing on the fragment, I am trying to land below the fragment, inside the disc. And this is an incorrect way of landing because we are too far in front and this is too far behind. We should be here. Our target is in the foramen. And what we do is, again I would repeat, we clinically have identified the location of the fragment. Then we try to locate it on the MRI. Then we try to extrapolate that to the X-ray. And then we try to extrapolate it to the scope. That is, when we put the scope, we try to imagine where should the fragment be. And we better land below the fragment. Now this may sound very complicated to you, but I'm sure tomorrow we'll be able to show you, or today we'll be able to show you what we really do. I would further simplify it. We are not doing a laparoscopic surgery. We are not doing a retroperitoneal surgery. We are doing a intramuscular paraspinal approach. This is my approach. It is not posterior midline, and I am sure that my target is the posterior annulus. What I am trying to tell you is my target is only limited to this. There is nothing else which I need to target. I just go through the foramen and try to target the posterior annulus. And this is a famous figure which all of us use. This is the foramen on the right side. The head of the patient is here, the leg is here, this is the dorsal, this is the ventral, this is the exiting root, this is the traversing root, and we are landing in this triangle. And on an average, this triangle is 12 millimeters this way, 18 millimeters this way, and 23 millimeters this way. 12 by 18 by 23. And the important point is this superior articular process of the inferior vertebra. For example, if this is L4 and L5, this is L4 nerve root, this is L5 nerve root, this is L5 superior articular process, which is always behind the disc. This relation of the disc to the superior articular process never ever changes. So this is used as a bony landmark when you are targeting the disc. Now this is a picture which is to make you understand very easily. This is a traditional foraminotomy or a laminotomy and removal of the ligamentum flavum. This is the dural sac. This is the root which is coming out of the foramen. Let us say this is L4, L5, L4-5 disc. This is L4 root. This is L5 which will come out from here. And this is the pars interarticularis. And in the next slide you will find that the same picture, that is, this is the foraminotomy, this is the midline, towards the head, towards the leg, on the right side, and this is where I land with my scope. So I am doing the surgery in the same area, but I am not cutting anything over here. I land like this in the axilla of the exiting root. I land below the pars interarticularis. This is my annulum. This is where I land. I land on the shoulder of the traversing root. So what I do is I try to, instead of going here, erasing the muscles and doing a foraminotomy or a laminotomy and then landing here, I come from here and I go like this. And for that, what I'm doing is I'm using the landmarks, that is the superior articular process and the bony landmarks, because I can see the bone on the C arm. And then what I do is I can come like this and then I decide whether I go below the facet or below posterior annulus depending on the target. Now there is an animation here which I will show you at the end of the presentation. And what we do is we try to go through these concepts, but ultimately we are trying to land in this triangle. This is the root which is coming out, this is the root which is going down, this is the triangle which I talked about, described by Cabin, and this is called as a safe triangle because this is devoid of any structure on the disc. So we can easily go in through that triangle. And important, it has two nerves which are live. So if you try to play with them, the patient immediately complains to you. When you are operating under local anesthesia, I try to teach this way, that when you are operating on the left side of the patient, I look at my own left hand. This is the traversing route, this is the exiting route, and I go here. And on the right side of the patient, I go here. This is the exiting route, this is the traversing route, I go on the exiting route. So here, for example, if I am going on this side, that is the right side of the patient, I will be going here. I would imagine that if I go too much like this, I will touch the exiting route. If I go too much horizontal, I will touch this. Normally I don't see this route because facet comes in the way. So I am mentally clear what I am doing and where the structures align. Now I would bring to your attention one more point, what I have written here. All of you are aware that there is a concept called a checklist, which most of the people who do precision work follow. Like the pilots, for example. You are aware that pilots have very less scope for making errors. They are not allowed to make any error, because if they make an error, they won't come back to tell you that they have made an error. So it's like training of a pilot. It's like training of a person who is doing an extreme precision job. And what you need to do is to understand where you are working, what you are doing, what are the dimensions, what are the tools, and what you are going to do once you are inside. There is no scope for playing around those structures, because these are important and these are very significant structures, and you must succeed every time. Now I for one would like to bring to your attention that we must come out of the concept of learning by making errors. That era has gone. My teacher always used to tell me that there is a way of learning by making errors. You must learn by making errors. I said no, you must learn by method. You must learn by precision. You must learn by technology. There is no scope for making errors, especially now that we have tools which can give you so much precision. You have MRI which can give you in millimeters what is the size, what is the location, etc. Why lose that advantage? Why again make the same errors and again learn through errors? So now what we are doing is in transfemoral surgery, we are landing in this area, which is between the exiting route and the traversing route. This green thing is the cannula which sits there, which indirectly is retracting this nerve, and which is making me aware that when I put my scope inside, the herniation is just going to be next to me. And you would find a small piece of annulus here, which may be between you and the herniation. And what we do in most of the cases is we go here inside. Now you must remember here one important thing. When you are doing a laparoscopy or arthroscopy, you are going in a cavity. There is space around. So you can play around, you can do many things. Here there is no space, there is nothing, it is just tight everywhere. So what you are trying to do conceptually is you are trying to land below the fragment, where the fragment has shifted out and created some space, right? So you go in the space where the fragment originally was. Therefore you land below the fragment. For example, this fragment which has come out might have been here, so you may have some free space here, or you create some free space, then you bring this fragment in and then take it out. So that is the idea of what we call as inside out. Now I strongly believe in that idea, mainly because I am very, very safe. Why? If I am inside the disc, there is no bleeding because there is no blood supply to the disc. There is no pain because there is no nerve supply to the disc. So staying inside the disc makes my job much more simple, much more easy and predictable. And since the patient is awake and aware, I am very, very safe. The patient can tell me if I am doing something which is wrong. Now I'll just take this one slide for anatomy, even though Stefan has already shown you in great detail. This anatomy is, we are looking at the left foramen. This is the superior articular process. This is the inferior notch. This is the superior notch, and we are landing below the superior articular process. This is the disc, and this is. So these are oriented. This is the cadaver specimen. This is the disc. This is the foramen. This is the superior articular process. Mind you, this will always be behind this. This relation will never change. This is the nerve. And then is essentially here. We are targeting all our efforts in the lower part of the body and on the posterior annulus. And what we are doing is we are aware that the nerve is here. So we are trying to stay away from this, and we are trying to work in this area under the facet or on the annulus in the foramen. And I will bring to your attention this paper, which is a very important paper talking about anatomical considerations in the lumbar posterolateral percutaneous procedures. This was in Spine 1995, and this talks about cadaver dissections and measurements at all levels, D12, L1 to L5S1, how much should be the size of the cannula, etc., etc. So this is a very important paper. And what we are doing, in short, this is a schematic diagram to show you what we are doing. We are putting the needle here under the guidance of the Siam. Then we take out the stylet, and on the in the place of stylet we pass a guide wire. This is a guide wire on which we pass this instrument called as a dilator or obturator, which is a blunt instrument, and then which lands on the annulus. Now when we land on the annulus, the patient tells us that the patient is getting some pain because the annulus is very, very sensitive. Then what we do is we put some local anesthetic on the annulus, and then on the dilator, on this, we put this cannula which goes here. And this is working as a retractor for the exiting route, and this is the tube through which we are going to work on or inside the disc. As I showed you this diagram, this is where we land in most of the cases, and then we work on this fragment or we work on fragments which have come out. And many times we may have to remove this piece of annulus which we call as collar of the herniation. That the herniation is coming out but is not moving because of this collar. So we cut this, then this becomes loose, we pull it in and take it out. So that's the way it works in many of the cases. And once you are there, then what? Then the first thing is you demonstrate the annular tear, because that is where the whole problem has started. Then you grab the tail of the fragment. The fragment has gone out. You are looking at the portion of the fragment which is inside the disc. You complete the removal of the fragment. And there are certain concepts called as adequacy of the surgery. This is one of the common questions which we have. How do you know that you have removed enough? So that we would probably be able to show you during surgery tomorrow. But this is a very important question. There are two simple answers. One answer is when you remove the fragment, it starts oozing inside the disc. Normally, since the annular tear is blocked by the fragment, there is no blood inside the disc. When you remove the fragment, the blood starts oozing inside. So the disc suddenly becomes reddish. There is a lot of blood which comes in. And secondly, as I told you, you ask the patient to extend on table. There is no pain going down the leg, which was there before the surgery. And there are of course various other ways of knowing whether you have done enough or not. Now this is a set of instruments which I use. This is what we'll show you, but I can tell you it's very, very simple. It is just these 7 instruments which you need for routine work. This is a needle, this is a guide wire, this is an obturator, a mallet, a cannula, a tapper. That's it. And of course the scope and other things. And these are all other advanced instruments if you're going to do everything about the disc and everything about everything. Now I would just take a few more minutes and bring to your attention certain very basic papers which probably initially would guide you into this type of surgery. This is a very, very important paper. This was in Spine 1995, and this talks about transforaminal and posterior decompressions of the lumbar spine, a comparative study of stability and intervertebral foraminal area. Now what it talks about is we do a traditional posterior midline surgery, and we do a medial facetectomy and try to sort of decompress the foramen. Why? Because most of the pathology is here, and we try to do a transforaminal decompression, which is like this. Now this was a cadaver surgery. This was a cadaver dissection and a paper based on cadaver surgery. So what it is talking is, if you have, this is the normal, this is where you have done a posterior midline surgery, a laminectomy, a medial facetectomy, and here you have done a transforaminal decompression. What it says is here you achieve about 25% of increase in the area of the foramen, but here you achieve about 43% increase in the area of the foramen. And mind you, the most important thing is here you have lost a lot of stabilizing structures. You have cut so many things which were essential for the stability, whereas here everything is almost intact. And this paper was written at a time when the concepts in spine endoscopy were not very well developed. So the paper says that there are three challenges in doing transforaminal surgery, which I am sure probably you would also have in your mind. That the first is, where is the space? Where is the place there? Where is the space there to do all these things? Second is, where are the instruments which can help me do all these things? And third is, how do I protect the nerve when I am operating? Now I have tried to answer all these questions to you, that the space is there, you are going inside the disc below the fragment. The instruments are there which are already available, we are using it for years together. And the protection is there by two things. One, we are very precise in going in the triangle. And second, the patient is awake and aware. So if you are fiddling around, the patient is going to tell you that he or she is getting pain going down the leg. Now there are two or three more slides. There are a few more applications of similar technique and instrumentation. Here, this slide is supposed to show you the dorsal ramus, where medial branch supplies the facet joint. Of course, the facet joint supply is not one level supply, it supplies the level above or level below. So when you are trying to do a denervation of the facet for treatment of backache because of facetal causes, you can do the surgery by the similar instrumentation, where you land on the transverse process and denervate the facet under vision by use of radio frequency or by use of laser. So this is one more application. And of course the other application is when we work in the foramen by undercutting this facet. The superior facet is cut by mechanical instruments like shavers, drills, or by laser or by hand instruments. So you can cut this and make the nerve breathe better, make space for the nerve, especially in lateral canal stenosis. Now this point is important because if you read papers related to failed surgery of the spine, almost 40% of the failures are because of missed or under-treated lateral canal stenosis. In the open surgery, you are not able to treat enough of lateral canal because you may not be able to access it very well, or you may not have the tools to do a undercutting of the facet. But since we are in the foramen, we can do a better job of lateral canal decompression by our technique because we are just below the facet in the foramen. So this is one more application. And then many times we have seen that in all these meetings when we talk about our concepts and our way of doing it, people ask me, but where is the literature? I am just trying to show you a list of 23 papers which talk about everything in endoscopic surgery. Just to give you an idea that everything has been talked about in endoscopic surgery for the last maybe 30 years. And many times I have seen that people feel that this is just yesterday or this is just last year. No, this has been going on right from 1976. And we have papers about everything from for extraforaminal herniations, intraforaminal herniations, paracentral, central, up migrated, down migrated, everything. All of them have been covered. And we have excellent papers on surgical technique. We have papers on other concepts. Even Stefan has conceptualization about disc effects, working on a contained herniation, working on annular tears, and then so many papers. So this was just to bring your attention that there is enough in literature talking about everything, even the recurrent herniations, failures in endoscopic surgeries, tackling lateral canal stenosis, then of course adolescent disc herniations, etc., etc. And then concepts on foraminoplasty, that is increasing the size of the foramen to go inside the canal and do the job. Now there are certain conceptual limitations today. The main limitation is going in the central canal behind the dural sac, then in a collapsed disc because the space available is very limited, and putting in cages and things inside the disc for fusion, which of course we are trying to overcome by various newer developments, which probably is for the fusion. Now what I'll do is I'll just play this video, which is about 2 minutes, which will tell you what I do. And I'm sorry it's not working in this presentation, but I think I should be able to play it through the media player. And I'll show you one simple half-a-minute animation. Now this is what is called a cine MRI. We have tried to, this is of course from an article, but I have also done this way. You are working under the MRI real time and you are trying to put a probe inside the MRI, there is a paraspinal probe basically. The patient's brain already knows where the problem is. Then he or she narrates to you that my problem is like this. So you imagine where must be the problem clinically. Try to demonstrate it clinically by doing Mackenzie's test and other tests, straight leg raising and urological examination. And then try to take the images, try to correlate the image with the symptoms. In 30% of the cases, it may not correlate. The image may not match what the patient is talking about. Either way, the image may look bad or the image may look normal. So then you go for MRI, the non-invasive assessment, and the invasive by doing a discogram. I do discograms in some cases, not all of them. And then you come to a conclusion that the target anatomically and physiologically in which area it is, say 4-5 foramen or paracentral or central or extrapyramidal. Then you plan your trajectory by drawing those lines, which will show you tomorrow or today evening. Then you put a needle followed by the steps of putting a guide wire, a dilator, a cannula and a scope. And once you start seeing it, then you work on the fragment, remove the fragment, and on table in most of the cases you are able to relieve the pain. And this can be done under local anesthesia. Why? Because the pain is arising from a very, very small limited area. It's not coming from the whole back. So this in short was my idea of telling you that this is doable, very simple but extremely precise way of doing it. And last point which I'll tell you is don't believe what our seniors used to tell us, that learn by making errors. No, learn by method. It's possible to be mathematical and precise and like shooting on the target, not everywhere, not shooting in your foot. So please do this.